Okay, good evening, everyone. First of all, I would like to thank PPS North Luzon chapter for inviting me as a speaker in the ninth CME. So the objectives are as follows: review the burden of childhood cancer, discuss the different risk factors in childhood cancer, discuss common genetic predisposition to cancer. Cancer is a major cause of death in children worldwide, and the recorded incidence tends to increase over time. The Automated Childhood Cancer Information System in Europe registers cancer incidence from 0 to 20 years old since the 1970s, and their latest results show that there was an increasing incidence for all cancers and was especially noted in leukemia. Every year, an estimated 250,000 new cases of cancer affect children under the age of 20 worldwide. That's almost 700 new kids affected every day. Every day, approximately 250 kids around the world die from cancer, or 91,250 kids lose their life to cancer every year. Cancer incidents in our country are derived from two population-based registries, Rizal and Manila, which covers for 14% of childhood population. In the Philippines, cancer ranks third among the leading causes of morbidity and mortality. That is 3,500 Filipino children diagnosed with cancer, or approximately 10 patients per day. According to Laudico et al., 80% of these patients could be potentially cured. However, only 16 to 20% attain long-term survival. More than two-thirds receive medical attention in the late stages of disease. Median delay in diagnosis of childhood, as reported by Felicius et al., are as follows: leukemia, 3 weeks; brain tumor, 9 weeks; solid tumors, 11 to 12 weeks. What are the importance of early diagnosis? So patients who are diagnosed early have improved prognosis, or patients with stage 1 or 2 disease would have better prognosis than those with stage 3 or 4. Although most of our patients present with the following symptoms, as seen on the right side of the of the PowerPoint. So it is difficult for us to immediately start treatment for them since they have additional comorbidities. So how do we make early diagnosis? Physicians should have a high index of suspicion. Why? Because early symptoms of these patients are non-specific. In a survey of pediatricians done by Arensberg et al. To pediatric cancer patients, 72% of these patients have general and unspecified symptoms. Only 20% showed alarming symptoms. So what are the different risk factors in developing cancers? The causes of childhood cancers has been studied for decades, and evidence regarding causal associations have been accumulating slowly. Childhood cancer vary by incidence according to age. As we can see in this bar graph, leukemia, lymphoma, and other embryonal tumors like neuroblastoma, Wilms, or retinoblastoma are highest in the younger age group and starts to dissipate by 5 years of age. For most childhood cancers, there is a slight male predominance, as you can see in this bar graph. Childhood cancer also differ by ethnicity. Relative to white children in the US, incidence is lower in Black, Asian, and Hispanic. However, In a few notable instances, cancer incidences is higher in other groups compared to white children, as shown in the lowest graph as shown in the lowest bar in the graph. Other risk factors studied are the external or environmental risk factors. However, only exposure to high-dose ionizing radiation and prior chemotherapy use have been accepted as a causal identifiable cause raising cancer incidence. Several intrinsic characteristics of children or their parents have been studied, like increased birth weight or advanced paternal age. However, the reason behind these findings are unclear and may include genetic mutations. Another risk factor in developing cancer are genetic factors. But before we go through the different genetic factors involved in cancer, let me briefly discuss the genetics of cancer. This figure shows the role of tumor suppressor genes and proto-oncogenes in tumor development. In healthy individuals, proto-oncogenes and tumor suppressor genes act as antagonists. The proto-oncogenes promote cell growth, while the tumor suppressor genes, as the name implies, inhibit cell proliferation. So when a sporadic or inherited mutation occur in proto-oncogenes, they become oncogenes that can orchestrate uncontrolled cell proliferation. According to Knodson's two-hit hypothesis, two mutation events need to take place in tumor suppressor genes for tumor development to start. In inherited cancer, the first mutation is inherited, and thus the probability of having cancer is greater in the general population than the general population. So most of these genes involved in genetic predisposition to cancer are tumor suppressor genes, and gain of function mutations in proto-oncogenes are only found in 10% of cases. In cases of predisposition due to mutations in tumor suppressor genes, individuals inherit a defective copy of the gene, but based on Knodson's two-hit hypothesis, tumor development requires the somatic loss of the other allele. Hence, mutations in suppressor genes are considered recessive. In the case of carriers of dominant or gain-of-function mutations in proto-oncogenes is different. Although a single allele suffices for cancer to occur, the presence of such mutation does not necessarily result in the individual developing cancer. This will depend on the clinical penetrance of each type of tumor. So hereditary susceptibility to cancer is suspected in families with two or more relatives with the same type of cancer, several affected generations, earlier age of diagnosis, individuals with multiple primary cancers, occurrence of different types of cancer that are genetically related, such as breast, ovarian, colon, and uterine cancer, increased frequency of bilateral or multifocal as opposed to unilateral involvement, and malignant changes in the same individual or family. However, because of phenotypic variability and age differences in penetrance, many families may not fulfill this criteria. So in the advent of cancer genetics, overwhelming evidence demonstrates that cancer is a result of multiple changes in the DNA of the tumor cells, including point mutations, large-scale copy number changes, and silencing genes by epigenetic changes. Children with constituted chromosomal abnormalities present with defined clinical phenotypes that can include dysmorphic features, congenital abnormalities, growth failure, and developmental delay. So due to these features, the increased association of specific chromosome disorders with malignancy was recognized earlier. So this table shows various X-linked and autosomal recessive syndromes associated with different cancer types. This is another table showing the autosomal dominant inheritance of the different cancer type. Encircled in red are the more common types like Beckwith-Wiedemann syndrome, neurofibromatosis type 1 and 2, and retinoblastoma. Another one of the most striking predominant predisposition to cancer caused by a child constitutional chromosomal abnormality is the nearly 20-fold increased risk in children with trisomy 21. The last and the most important factor in early diagnosis of childhood cancer is recognizing the red flag signs. And these are the following: continued or unexplained weight loss, which are seen in most of our cancer patients; headaches with vomiting in the morning, seen in patients with brain tumors, or retinoblastoma patients with intracranial involvement; increased swelling or persistent pain in bones or joints, sometimes accompanied by limping. So this can be seen in bone tumors like osteosarcoma or leukemia patients. Lump or mass in the abdomen, neck, or elsewhere, seen in our solid tumors like Wilms, germ cell, neuroblastoma, or it can also be lymphoma. Development of a whitish appearance in the pupil of the eye or sudden changes in vision, as seen in our retinoblastoma patients. Recurrent fevers not caused by infections, usually seen in most of our cancer patients. Excessive bruising or bleeding, seen in leukemia patients. And noticeable paleness or prolonged tiredness, also seen in most of our late-stage cancers or leukemia patients. So these are all. Thank you.